You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 19th, 2021. This week, an announcement and then an AHA review version 1. Now, next week is Thanksgiving break, and so TWIC will return on December 3rd. Before I get to the AHA review, I want to say thank you to all of those who've sent me comments over the year. I talk into this mic each week and wonder how it is received. Both positive and negative feedback is appreciated, so please keep it up. I also want to say a word of thanks to my colleagues and editors at theheart.org for their support and mentorship in learning to do critical appraisal. Now to the AHA review. I won't be able to get to all the studies in one podcast, so look for part 2 when I come back in December. First up is Avatar. This was an RCT of early surgery versus watchful waiting in patients with severe aortic stenosis. Now, these patients had to pass an exercise test where they achieved 85% of their max heart rate, and that ensured that they were actually asymptomatic. Circulation published the paper. There were about 157 patients, mean age 67, so pretty young. The cause of aortic stenosis was degenerative in greater than 80% and bicuspid in only 14%. Over a median follow-up of 32 months, the primary endpoint of all-cause death, MI, stroke, or heart failure hospitalization occurred in 16.6% of patients in the early surgery arm versus 32.9% in the conservative arm. The hazard ratio was 0.46 with confidence intervals ranging from 0.23 to 0.90, and the p-value was significant at 0.02. When you looked at the Kaplan-Meier curves for the primary endpoint, they separated at just before a year. Now, there were some peculiar observations regarding the components of the composite endpoint. The primary endpoint was driven by all-cause death. There were 16 deaths in the conservative arm versus 9 in the early surgery group. But get this, cardiovascular deaths were not different, approximately 9% in both arms. Now, I say this is peculiar because if early surgery helped young patients with aortic stenosis, you'd expect it to do so by reducing cardiac-related death. So my translation of this very important trial is that you have to go deeper than the top-line results. On the surface, you have a significant 54% reduction of the primary endpoint, and the results in Avatar are similar to the South Korean early surgery versus watchful waiting recovery trial. It sounds like a no-brainer then, right? But I don't think so. First, the results here are fragile. If only 2 patients in the active arm converted from not having the primary endpoint to having the primary endpoint, the study would lose statistical significance. Look at the differences in death. Why, if early surgery was so beneficial, wasn't cardiovascular death lower? Now, it turns out that the authors tell us in the supplement, always look at the supplement, that 3 watchful waiting patients versus 0 in the early surgery arm died of COVID viral pneumonia. Now, that surely seems due to the play of chance. The other issue in translating Avatar and recovery to practice is generalizability, or what we call external validity. Now think, these were young, mobile patients with aortic stenosis. Most patients with trileaflet degenerative severe AS that I see, however, are older and they come with comorbidities. So we should be very careful applying fragile results to the typical older patient with aortic stenosis. Why? Because older patients are going to have a much tougher time with surgery. And my friends, remember, preventive medicine always means doing something to people who have no complaints. Since all interventions have a risk of harm, before we intervene, we should have a high bar that benefits are greater than harms. When the preventive intervention involves sternotomy and cardiopulmonary bypass, the bar should be much higher than these two small trials. In fact, the Avatar authors themselves called for this in their paper, writing that, quote, "These findings will require further confirmation in a larger study." Now, before I move on, I know what your rebuttal may be because one of my structural heart partners reminded me that TAVR is different from surgical aortic valve replacement. TAVR is less invasive, and yes, maybe you don't want to subject an older patient to preventive surgical AVR, but TAVR represents a less invasive option. And sure, this thinking makes total sense, but I would argue that it is an entirely testable hypothesis. You take 80-year-old patients with severe but asymptomatic AS and randomize them to TAVR or watchful waiting and then measure outcomes. The second topic today is tricuspid valve repair. Another big trial at AHA also studied a heart surgery question, one that I've always wondered about. When patients go for mitral surgery for degenerative MR, should the surgeon also do a tricuspid annuloplasty or tricuspid repair? I wonder about this because electrophysiology is consulted for pacemakers after heart surgery. The New England Journal of Medicine published this trial from the Cardiothoracic Surgical Network. 401 patients. These patients had to have moderate TR or if less than moderate regurg, annular dilatation of 40 millimeters or more. The active arm of the trial was the mitral plus tricuspid valve annuloplasty, and the control arm was mitral surgery alone. The key feature of this trial was the primary endpoint. And as I tell you what it is, think if you notice anything amiss. The primary endpoint was a composite of death, reoperation for TR, or progression of TR by 2 grades from baseline or the presence of severe TR. The hint, of course, is that you have 2 hard binary endpoints, alive or dead, reoperation or not, and then you have ultrasound estimation of a TR jet. The primary endpoint occurred in 10.2% of patients who had mitral surgery alone versus 3.9% who underwent concomitant tricuspid annuloplasty. The relative risk ratio was 0.37, and the confidence intervals went from 0.16 to 0.86, and the p-value was significant at 0.02. But, my friends, the endpoint was driven exclusively by less TR progression in the repair group. Just 0.6% of the annuloplasty group had TR progression, compared with 6.1% of the surgery alone group. The other 2 components of the primary endpoint, there were 0 reoperations in either group and no significant difference in death. Here's the kicker, though. The rate of permanent pacemaker implantation was 2.5% with mitral surgery alone versus 14.1% with concomitant tricuspid repair, a greater than 5x higher rate. Now that is, of course, because sewing in the annular ring involves placing a stitch in close proximity to the conduction system. I've written a column on this trial. I hope you read it. Proponents would say that it's a positive trial, tricuspid valve repair, reduced TR, and that is a good thing because TR is bad and reoperations for TR are especially high risk, so it's better to prevent regurgitation. I disagree on this interpretation of the trial. This is an underpowered trial for hard endpoints. Tricuspid regurg is a terrible endpoint because it is susceptible to measurement error. It's dependent on pre- and afterload, and no patient ever has complained to me that his or her TR jet was abnormal. For the price of a better ultrasound image, there was a 5x greater rate of pacemakers in a group of patients who were less than 70 years old. As a pacemaker implanter myself, I say this is a bad trade-off. You always want to hold off on pacers for as long as possible. Now here's the thing, the trial could have been larger. The same Cardiothoracic Surgery Network recruited more than 2,000 patients to study rate versus rhythm control for post-op AFib. Richard Whitlock and his group in Canada randomized more than 2,300 surgical patients for left atrial appendage closure at the time of surgery. This is important because I have heard Vanderbilt stats professor Frank Harrell say that underpowered trials that cannot answer a clinical question are problematic. Why? Why? Because remember, a clinical trial is an experiment on humans. If you're going to do experiments on humans, you ought to strive to get a clear answer. If you're going to increase the odds of needing a pacer because of AV block, we need a trial with more patients followed for longer. Until then, we ought to favor, in the average patient with moderate tricuspid regurgitation or a dilated annulus, the conservative less is more approach. Third topic is the PALACS trial, P-A-L-A-C-S trial. This is another cardiac surgery trial at AHA. This one's interesting. Post-cardiac surgery AFib. This is one of the toughest problems in all of cardiology. In 2 decades of practice, everything I have seen tried has failed to prevent AF after heart surgery. In fact, I've come to believe the only way to avoid AF after heart surgery is not to have heart surgery. The PALACS trial randomized cardiac surgery patients to a posterior pericardotomy or no intervention. Lancet published this paper. They screened about 3,600 patients but randomized only 420, so pretty selected group. They excluded those undergoing mitral or tricuspid surgery or with a history of previous atrial arrhythmias. They ended up with mostly CABG and AVR patients. Now, posterior left pericardotomy is a simple surgical procedure that connects the pericardial sac with the left pleural space, and it drains fluids and thrombi from the pericardial cavity in the postoperative period. The idea is that even a small amount of fluid in the pericardium could be causal in the AF. The results of this trial, AFib occurred in 17% in the posterior pericardotomy group versus 32% in the control arm. The odds ratio is 0.44, and the confidence intervals range from 0.27 to 0.70. The incidence of post-op pericardial effusion was lower in the pericardotomy group than in the no intervention group, 12% versus 21%. Adverse events were not different, and there were no complications related to the pericardotomy, and there were only 4 extra minutes of pump time. This sounds amazing, right? Well, maybe. Remember, this was a single-center proof-of-concept study. One surgeon did the most of the patients in the trial. The investigators are already planning another bigger trial, and good on them. And I love this stuff for many reasons. One is that the trial received no funding. The surgeons at Weill Cornell Medical College were just curious. But instead of just doing things willy-nilly, they studied it with proper controls. We in electrophysiology could learn from this. Take our ablation approach to persistent AFib. Some of us do just PVI, others PVI plus posterior wall, other PVI plus triggers, others PVI plus lines. Whenever there is an expert panel at a meeting on the ablation approach to persistent AFib, there are almost as many approaches as panelists. We've been ablating AF for decades now, and all it would take is a couple of systematic trials like this one the surgeons did. Now, we've had a handful of trials, notably STAR-AF2 from Dr. Atul Verma, but not many others in ablation. The point here is that if these heart surgeons had simply done posterior pericardotomies and then happened to notice less AFib, then went back and did an observational chart review, you'd never know the answer, no matter how many statistical adjustments or propensity matching maneuvers you did. By doing a randomized trial, you increase the chance of detecting true differences because the randomization balances the known and unknown patient characteristics. Next topic is left main coronary artery disease. In a featured science presentation at AHA, Mark Sabentine from the TIMI group at Brigham and Women's Hospital at Harvard presented results of an independent analysis of the left main PCI versus CABG trials. The Lancet published a paper. Now, the reason for this meta-analysis stems from controversy surrounding the XL trial, which was the largest of the 4 left main PCI versus CABG trials. And I've talked about this before, but in brief review, the 3 XL controversies were: 1, the signal of increased death in the PCI arm, which was not seen in Noble, the other big left main RCT. XL authors posited that the higher death was due to chance because they found no differences in CV death. The second debate around XL stemmed from the author's biomarker-dependent definition of MI, which favored PCI due to peri-procedural MIs being higher with CABG. And the third controversy, and perhaps biggest one with XL, was that the XL trial protocol called for reporting MI rates by the universal definition of MI. But the authors did not include these in either 3 or 5-year papers in the New England Journal. And this was only discovered because the trial data was leaked to the BBC News. Had there not been an insider who leaked the data, it's possible no one would have known. And, of course, MI rates defined by the universal definition of MI favored the CABG arm. So the way to resolve these issues was to get an independent review. The meta-analysis took individual patient-level data from the 4 trials, Syntax, Pre-Combat, Noble, and XL. The follow-up was 5 years. The authors chose as their primary endpoint all-cause death, and they reported it in both a standard frequentist terms with p-values and also in Bayesian terms. So the results were that death was 11.2% in the PC arm versus 10.2% in the CABG arm. The hazard ratio was 1.10, and the 95% confidence intervals ranged from 0.91 to 1.32, and the p-value was not significant. But in their Bayesian analysis, they found that the probability of any mortality benefit of CABG over PCI was 85.7%. The probability that the mortality advantage of CABG was as great as 1% in absolute terms at 5 years was about 50-50, 49%. Spontaneous MI was 2.3x more likely in the PCI arm. Stroke was not significantly different at 5 years. Repeat procedures for revascularization were 78% higher after PCI. And for the broader composite outcome that all cardiovascular trials use, this composite was death, MI, stroke, or revascularization. That was 31% higher for PCI versus CABG. So I see 3 main takeaways from this Mark Sabatine et al. Meta-analysis. One is that this is a breakthrough in medical evidence communication. I mean, this is huge. TIMI investigators, the group of Eugene Grunwald from Harvard, reported an important finding published in The Lancet using a Bayesian analysis. Why is this so big? Because as clinicians, we love the Bayesian point of view, because we want to know the probability of benefit given the data. Now, the traditional approach with p-values tells you how surprising the data are given the made-up hypothesis of no difference between treatment. But clinicians like us, we don't make up null hypotheses and then calculate the probability of the data given no difference. We look at event rates in 2 arms of the trials, and we want the probability of benefit given those results. In this case, there is an 85% probability that mortality is better with CABG, and a 50-50 chance that CABG produces a 1% absolute risk reduction in death, which doesn't sound very big, but there's a lot of things in cardiology we do because of 1% differences. I encourage you all to look at the probability density function in Figure 5 in the supplement. It shows how they get these percentages, and it is quite simple. This can be easily done with most trials. And I think the coolest aspect is you can decide what you think the minimally clinically important difference is. It might be a 1% reduction, it might be a 5% reduction, but whatever it is, once you have that probability density function of the Bayesian approach, you can tell what the probability of that minimally clinically important difference is. The second takeaway of this meta-analysis is that given the average patient who is eligible for either PCI or surgery and randomized in these 4 trials, CABG is the better strategy on paper. At 5 years, CABG delivers an 85% probability of lower mortality. There's less MI, less repeat procedures, and no difference in stroke. Patients who have left main disease ought to come off the cath lab table for a discussion about options. It's not, sir, you have blockages, I can fix them. Which leads me to my third takeaway, which is that even though the odds favor CABG, there's a clear difference in trade-offs. I mean, everybody knows that PCI is way easier on people in the short run. I mean, some patients may decide that the surgical outcomes aren't that much better. They will take the Band-Aid on the wrist and discharge in 1 day. Some patients will have subtle anatomical or clinical features that may favor one therapy over another. A neutral heart team approach would be ideal. But as I wrote in my commentary out today, this is easier said than done. Cardiologists and surgeons are human, and humans are complicated, and we're full up with different experiences and biases. In the perfect world, there would be no other competing interest in a heart team meeting other than helping a patient make the most informed and values concordant decision possible, and we can aim for that perfect world. Now, when I return the Friday after Thanksgiving, we can talk more about the AMAZE trial. Epicardial left atrial appendage closure with Lariat added no benefit to AFib ablation. Now, this one's going to be hard on believers in the left atrial appendage as a frequent driver of AFib. The group of Dr. Greg Marcus at UCSF presented 2 studies on AF triggers, including, you guessed it, caffeine. There'll be a study looking at the effect of preventive aspirin on dementia. I'll discuss the failure of EHR alerts about heart failure prognosis to change outcomes or clinical practice. This is a non-significant results trial that teaches us a bunch. And there will also be 2 studies on SGLT2 inhibitors that were both positive at AHA, but had huge caveats. And the teaser is that this class of drugs can deliver big value in some patients, but I'm afraid in other classes of patients the value is likely low. And it should come as no surprise that the same treatment can be both on the steep and flat part of the value-utility curve. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, friends, if you like this podcast, please tell your friends. Take the time to give us a rating or write us a brief review. Those sorts of things help others find us. Until the Friday after Thanksgiving, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.